So, good evening, ladies and gentlemen. My name is Dr. G C Khilnani, working as a chairman of PSRI Institute of Pulmonary Critical Care and Sleep Medicine. And previously, I had an opportunity of working at All India Institute of Medical Sciences. And I'm your moderator who will be moderating this session. Uh, Talking about non-invasive ventilation, my relationship with NIV, as I've recited, is almost 35 years now, as we started using it in the early 90s, and we have come a long way. When we started using NIV, we used to shout aloud and say that NIV can be used only in intensive care unit where full facilities are available, ventilators are available, and only indication that we knew of was respiratory failure secondary to chronic obstructive pulmonary disease, and maybe for neuromuscular weakness, kyphoscoliosis. And we used to say almost no to hypoxemic respiratory failure. Of course, the asthma still continues to be a doubtful indication, but we have come a long way. The machines have improved, the techniques have improved, the masks have improved. Our understanding of the non-invasive ventilation has improved, and then came COVID. During COVID, we was a very big help to the intensivist and the pulmonologist and physicians at large, where NIV was used initially with a lot of skepticism that this will disseminate the COVID, but subsequently that was not found, and NIV was used in a big way. Today, almost all the cases with acute respiratory failure are tried with non-invasive ventilation because the moment you put the patient on ventilator, there is a lot of complications, especially ventilator associated pneumonia, and mortality goes high. As we know that uh, once the patient is on ventilator, there could be, beside the VAP, there are several other complications. So therefore, NIV is a part and parcel of medical care, be it intensivist, be it pulmonologist, be it internal medicine person. There's an immense interest in that. And I'm thankful to our Indian Chess Society and the Messer Sipla for supporting this activity, and especially Dr. Amita Nene, who is actually spearheading this program with the weekly webinars. And I believe that more than 1,000 people are already logged in by 8:30, and I think there are more to come. And I have amazing faculty with me, starting from Dr. Parvaiz Koul to Dr. Gyanendra, Dr. Mansi, Dr. Dr. Priti. So we are going to have amazing discussion. So introducing the star speaker of the day, Dr. Gyanendra Agrawal. He has done DM Pulmonary Critical Care Medicine from iconic PGI Chandigarh, and currently is working at the JP Hospital Noida. I have had an occasion of uh, seeing him grow and hearing his talks. One was almost 2 weeks back. He is going to give an overview of NIV for say 25-30 minutes, and subsequently we'll be indulging into a structured discussion where all the faculties would be joining, and then we'll take questions from the audience, and we'll try to finish in stipulated time. So, Dr. Gyanendra, all is yours. Please let us know all about NIV.
Thank you so much, sir, for your kind words. Coincidentally, your years of experience are just short of my age, and you were one of my examiners in DM examination. So, of course, we all have learned a lot from you, and we keep on learning from you. And it's really an honor for all of us to share the platform with you. So, good evening, my dear friends. And NIV is a huge, huge topic. It won't be possible for me to cover everything in these 20-25 minutes, but I'll just try to give you an overview. And in the interest of time, I'll be focusing mostly on NIV in acute care settings, in the ICU settings. Of course, we all know that NIV is used in a much bigger way as a part of domiciliary care in a large subset of patients, especially with COPD and chronic respiratory failure. But today I'll be focusing mostly on NIV in acute care settings. So, in the practical approach for the success of NIV, we need to know three most important things: the good patient selection, little bit about the equipment, and definitely the skills which the clinician should have it. So, coming to the most important thing, the indications of NIV, and I am sure all of us, even in mid of night, if we are asked about the best indication of NIV, it is the acute exacerbation of COPD. Now, this is the most important indication of NIV, and this is really a boon for COPD patients who come with acute severe exacerbation in ICUs. So, any patient who has got severe dyspnea with signs of respiratory failure or impending signs of respiratory failure, they are the candidates for NIV. Like if they are using accessory muscles of respiration, if they are having paradoxical respiration, and if they are having hypoxemia. Now, more important than hypoxemia, if they are having respiratory acidosis, which means if the pH becomes less than 7.35, then it becomes the indication for NIV. And the earlier the NIV is used in these patients, the better would be their outcome. Now, this becomes a very, very important indication for NIV. But an important point here to note is that this is one such good indication of NIV that it is recommended that NIV may be attempted even in patients when the pH goes below less than 7.25 for a little while. And actually, they say there is no lower limit of pH below which a trial of NIV is inappropriate. Now, this is different from the conventional teaching, but COPD, the results with NIV are so good that it has been used even in comatose patients with NIV. We know the first and the foremost prerequisite of NIV is that the patient should not be having altered sensorium and he should be cooperative with the medical team. But in COPD, there is good data to suggest that even if the patient is having some altered sensorium, NIV could be used for a little while and see if the patient is improving. But then an important thing is the lower the pH, the higher the chances of NIV failure. And we must recognize the NIV failure at the right time in these patients so that we don't do harm in these patients. So the advantages of NIV in acute exacerbation of COPD are multiple. It helps in multiple ways. The most important thing is it has got the mortality benefit and it becomes the most important indication for NIV, the grade A recommendation. So as such, if we see the respiratory failure, they are of two types, type 1 and type 2. So NIV is particularly useful in patients who have got type 2 or hypercapnic respiratory failure, as opposed to type 1 or hypoxemic respiratory failure, where NIV is not that useful. Yes, it can be used in initial stages, but the evidence for using NIV is much more in type 2 respiratory failure. So extending this indication of chronic respiratory acidosis. So what are the other common causes of chronic respiratory acidosis which we encounter in our ICUs who come with acute and chronic respiratory acidosis? Obesity, hyperventilation syndrome, patients having long-standing bronchiectasis, small airway diseases, patients having chronic neuromuscular respiratory failure, chest wall deformities, or corpulmonal because of any other disease. So all these will obviously become the good indications for NIV if the patient comes with acute and chronic respiratory acidosis. The second most important indication for NIV in ICUs is the cardiogenic pulmonary edema. Nowadays, we intensivists, pulmonologists do encounter a lot of patients with cardiogenic pulmonary edema, particularly patients who come with preserved ejection fraction. The cardiologists, they refuse to, or they are not that interested if the coronaries are good in these patients. So the facts are that the bilevel decreases the need of intubation and it is associated with reduction in the hospital mortality. It is not associated with the increased risk of myocardial infarction, and both CPAP as well as bilevel can have similar effects on these outcomes. But we must be cautious if the patient is having cardiogenic shock, if the patient needs acute revascularization because of acute coronary syndrome, then in that case, NIV should not be used. And if the patient is having respiratory failure, it is better to intubate those patients. Immunocompromised patients, if they get pneumonia, now this is one subset where the endotracheal intubation is associated with significant mortality. So NIV helps in decreasing intubation rate, but then data is little conflicting. The benefits are seen in patients who have got solid organ as well as the hematological transplant and immunocompromised patients because of anything when they come with pneumonia. The other common indication is NIV to prevent reintubation. Now, there are two strategies or two settings where the patient may require reintubation: NIV with extubation and NIV after extubation. So, there is some difference between these two terms. If the patient is requiring, or if the patient is given NIV before he actually develops respiratory failure, it is called NIV with extubation as soon as the patient is extubated. And if the patient is given NIV after they develop respiratory failure after extubation, then it is called NIV after extubation. Now, this indication, NIV with extubation, in at-risk patient is definite indication for NIV, and it really works well. And who are the patients who are at risk for the post-operative respiratory failure? Elderly patients, particularly who have some underlying cardiac or the respiratory disease. Now, patients who have got post-operative respiratory failure, NIV may not be the good choice, and it may increase the mortality. And it is very important to timely recognize this entity and maybe reintubate the patient if they develop respiratory failure after the extubation. Post-operative hypoxemia, NIV works well, and that is also one of the good indications for NIV. So one very important thing, or one very important like diseases, set of diseases which we encounter in our clinical practice in ICUs are the hypoxemic respiratory failure, or what are called as ARDS. Now, do NIV is indicated in patients of acute hypoxemic respiratory failure. So one dictum is that NIV should be discouraged in patients who have got severe ARDS or when the PF ratio is less than 150. NIV may be used with caution in early or what is called as mild to moderate ARDS if the PF ratio is more than 150, particularly if it is used in a protocolized way. And there is some debate on which is the right interface in these patients, whether we should be using oronasal, or there was some previous data to suggest that the helmet might be a good interface in this subset of patients. NIV NAVA, I have no experience, but I'm sure Dr. Khilnani sir has some practical experience, and he will like to throw light later on during the discussion on these advanced modes of NIV. So NIV is to be used with a lot of caution in patients who have got acute hypoxemic respiratory failure, because it may cause more ventilator-induced lung injury. And the reason is very clear. These patients are conscious, their respiratory rate is high, their minute ventilation is high, and if we are supporting their respiration with NIV, then it can actually lead to generation of high tidal volumes, which defeat the most important life-saving strategy of low tidal volume in these ARDS patients. The PEEP, again, which has got mortality benefit in ARDS patients, may be inadequate with NIV, and NIV may actually lead to some false hopes, and one may delay intubation in these patients, which may be deleterious. So NIV should be used with a lot of caution in patients with acute hypoxemic respiratory failure. Obviously, the first and foremost prerequisite is the patient's cooperation. So if the patient is confused, if the patient is agitated, or if the patient is in altered sensorium, that becomes the contraindication for NIV. If there is hemodynamic instability because of any cause, be it septic, cardiogenic, or for that matter, any other cause, then it also becomes the contraindication for NIV. Undrained pneumothorax, obviously, it will increase. It will become tension pneumothorax if we give them NIV. If the patient is having copious secretions, frequent vomiting, there are more chances of getting him aspirated. So that becomes the contraindication for NIV. And for that matter, any other reason by which we are not able to use the interface in these patients, like recent facial surgery or facial trauma, burns, anything. So obviously, we can't use NIV in these patients. The other points which we need to understand about the NIV are the equipments. So there are broadly two sets of ventilators in our ICU. One are the portable ventilators and the conventional, the critical care ventilators. The critical care ventilators, of course, are better in acute care settings, whereas the portable ventilators are probably better in the chronic care settings or the domiciliary care settings. Critical care ventilators give us the better waveforms. The FiO2 which is given to these patients is more reliable and accurate. And there is always a backup for invasive ventilation if the NIV fails in these patients. Portable NIV ventilators have got a big advantage that the air leak compensation is very good in these portable, and they are, of course, more handy. And they can actually be used in the step-down units like in HDUs and in wards also. So portable NIV ventilators are also useful in these patients. Now, which interface, whether we should be using oronasal, full face, nasal, or the helmets. So the most common interface which is used in clinical practice is this oronasal mask. However, what is an ideal interface? It should be a lightweight, easy to secure. Obviously, it should be having lead, low dead space, and it should be compatible with wide range of ventilators. So it should be comfortable for the patient. So what about helmet? Helmet is one interface which is particularly useful in patients who have got ARDS or type 1 respiratory failure. And it has been shown that it decreases the intubation rate, ventilator days, and to some extent, mortality also. So they are more comfortable and they can be used for longer periods of usage. There's no facial breakdown, higher PEEP can be given, and in fact, lung recruitment maneuver can also be done with helmets. So they are primarily used in patients who have got type 1 respiratory failure. They are more comfortable. They permits longer periods of continuous application. Now, the disadvantages are that they have got higher or the more dead space. The chances of CO2 rebreathing are much more with these helmets, and they require greater inspiratory muscle effort and time to achieve the selected airway pressure. Now, two basic or the most important modes which are commonly used. I'm not going into advanced modes of NIV today, but the basic modes, CPAP, the continuous, and the BPAP, the bi-level positive airway pressure. So CPAP is most commonly used or widely used or indicated in patients who have got cardiogenic pulmonary edema and acute hypoxemic respiratory failure, whereas BPAP is mostly useful in patients who have got hypercapnic respiratory failure, cardiogenic pulmonary edema, which is refractory to CPAP, and also once we are planning to wean off the patient from mechanical ventilation, especially patients who have got chronic respiratory acidosis, we try to wean them off with NIV support, try to extubate them early, and give them NIV promptly. How to use NIV practically? Again, it's a art, clinical art, and the most important prerequisite or the most important factor which determines the success of NIV is the patient's cooperation. And patient will cooperate once he or she is comfortable. So we need to explain this NIV to the patient. We need to tell them that we are going to put on a mask on your face, and instead of directly going on to straps, it is better to hold mask for first few minutes, make the patient comfortable, adjust the settings, and keep on motivating the patient. That is very, very important. And that is why it is said that NIV is much more labor intensive as compared to mechanical ventilation, where the patient is intubated, sedated, maybe NMBAs are given, and then we can rest for some time. But with NIV, we have to be on the toes all the time when the patient is on NIV. So patient's cooperation is of utmost importance when the NIV is given to these patients. And how can we improve the patient's comfort? We can give them NIV in the sitting or the reclining position, avoid excessive strap tension, start with the low pressure, gradually increase them, and allow patient to get some time for their meals and the drinks. And definitely regular motivation and the encouragement is required. Initial settings, CPAP or EPAP of 4 centimeters of water and IPAP of around 8 centimeters of water. And then one can gradually increase depending on the requirement and depending on the EBG values. So IPAP can go up to 20 centimeters of water, and we should maintain, if we are using the bi-level, we should maintain at least 4 centimeters of water difference between the IPAP and the EPAP. Obviously, targeted oxygen therapy or titrated oxygen therapy should be given, and one should avoid hyperoxemia in these patients. The trigger setting should be preferably be on the lower side, and the expiratory trigger or the cycling off, which is called, should be approximately in the range of 40 to 70% of maximal inspiratory flow. Monitoring. Now, this is the most important thing which one must be doing while applying NIV, especially when the patient lands in the ICU in the initial few hours. And it is not very difficult. We just need to monitor very few basic things. Sensorium of the patients, basic pulse, BP, respiration rate, and EBGs. If we do so, we will be able to justify and we will be able to decide when the NIV is working or when the NIV is failing. So a simple chart, this is a simple thing which we do practically, and it works very well in majority of the patients. We assess them at the end of 1 hour when we start NIV, at the end of 2 hours, at the 4 hours, and just these basic things: sensorium, heart rate, BP, respiratory rate, honest respiratory rate, and PF ratio by doing the and based on this, if these values are improving, then definitely the NIV is working. However, as you see in this particular patient, the NIV is not working and it has failed. So this patient required intubation. Alarms and troubleshooting. There can be multiple alarms with the NIV machine. Uh, the most common alarm which we see is the low pressure alarm or the patient disconnect alarm, where one must check for the leaks. And the high pressure alarm are usually because of some blockage or because of bronchospasm in these patients. Filters must be checked in these patients. Now, if the patient is having persistently elevated arterial CO2, so this is one very good equation which tells us about the determinants of arterial CO2 in any patient who is admitted to ICU. So based on this equation, if the patient is having persistent hypercapnia, then one can increase the tidal volume, can decrease the dead space, can decrease CO2 production, or can increase the respiratory rate. So how can we do, or how can we achieve these basic principles to actually target the hypercapnia? So we can increase the IPAP. We can the difference between the IPAP and EPAP can be increased to take care of PSCO2 to increase the minute ventilation. If the EPAP is set at very high level, say more than 8 centimeters of water, then it can be decreased. The inspiratory time must be adjusted and more time should be given for expiration. The rebreathing should be checked. The dead space must be reduced in whatever way it is possible. The oxygenation must be, it should not be very high oxygen and it should be a titrated oxygen therapy. One can always check for excessive leak and compliance. And the important thing is one must check for the chest expansion because that could lead to inadequate ventilation in these patients. And if there is difficulty in chest expansion, of course, we should look at our patient again, look for bronchospasm, mucus plugging. Maybe the patient could be having pneumothorax, atelectasis, collapse, consolidation, edema, or simply the tube could be kinked. So all these simple things, if they are looked upon, in majority of the patients, we'll be able to see what is happening in this particular patient and we'll be able to troubleshoot them. If the patient is having hypocapnia or alkalosis, then it means that the minute ventilation is too high and we need to reduce the IPAP. And we actually need to see if the patient still requires ventilation. So that probably this particular patient may probably be weaned off from NIV. So we'll see how can we wean off from the NIV also. If the patient is, say, having persistent hypoxemia, particularly type 1 respiratory failure, then of course we need to increase the FiO2 and we need to increase the EPAP or the CPAP. But we must also simultaneously remember to increase the IPAP in these patients. And of course, the oxygen entrainment into the circuit must also be looked upon. Now, persistent hypoxemia in acute hypoxemic respiratory failure, one should not delay intubation because delaying intubation increases mortality significantly and only checking on the SpO2 should not be relied upon. So all parameters which we have seen, sensorium, respiratory rate, pulse, BP. So all these things should also be taken into account. And if the patient is not improving in all these parameters, one should not delay intubation, particularly in patients with ARDS. And these patients should be timely intubated so as to save them from the deadly disease. If the patient is having, say, agitation or confusion, then we must look for any metabolic causes of this problem, like the electrolytes, maybe hypoxemia, hypercarbia, and sometimes light sedation with dexmedetomidine or maybe remifentanil may be used in these patients. The long-acting benzodiazepines should preferably be avoided in patients who are on NIV. Now, NIV failure. Now, it is very important to recognize the failure of NIV timely. And if the patient is having worsening sensorium, worsening respiratory failure, hemodynamic instability, and worsening gases, then obviously it means that the NIV is not working in this particular patient and we need to check upon what is the cause of NIV failure. So one must review the diagnosis. The initial diagnosis or the initial syndromic diagnosis in the ICU may be looked upon again. And by that time, we have good amount of data. We have some more investigations to help us whether this is the correct diagnosis where we are approaching so that we can actually target the particular disease timely. Optimizing the treatment of primary disease remains the mainstay of treatment. And we can also look for any additional complications once the patient has been started on NIV, like pneumothorax, aspiration pneumonia. Pulmonary embolism is one thing which we all of us must keep in mind when the patient comes with respiratory failure, whether it is type 1 or maybe type 2. Now, important thing about the NIV failure is the patient ventilator dysynchrony or asynchrony. This is again a big topic in itself, and I'm not going into details of this. So broadly, we have two types of asynchrony. It could be trigger asynchrony, like the trigger could be ineffective. It could be like patient could be triggering double, or it could be auto triggering. or it could be cycle asynchrony, like the premature cycling or the late cycling. Now, to overcome this problem of patient ventilator asynchrony, one must always look for air leaks because that is the commonest cause of any dysynchrony or asynchrony which occurs in these patients. So, air leaks anywhere in the circuit must be, and especially in and around the interface, must be looked upon. And if we minimize the air leaks, most of the time, the NIV works well in these patients. We can switch to time mode to decrease the persistence of ventilator inspiration into expiration occurring in the bi-level modes. We can decrease the pressure support when the tidal volumes are very high and the breathing efforts fail to trigger. Mild sedation can be given in these patients, again under constant monitoring if he or she is very much agitated. And advanced modes like EVAPs or maybe PAV, proportional assist ventilation, could be used in a small subset of these patients. So once we are through the NIV, the patient is improving on NIV, then we need to wean them from NIV, which can be done suddenly. Abruptly, you stop the NIV and give them oxygen or maybe observe them closely. That is called sudden weaning from the NIV. Now, the advantages definitely are that it decreases the total length of ICU stay, but it is said to be more effective in patients who have got primarily type 1 respiratory failure. Gradual weaning is always better tolerated, particularly in patients who have got type 2 respiratory failure, and there are less chances of NIV failure in these patients. So we try to decrease the pressure support or the IPAP or EPAP gradually in these patients, and then try to wean them off. We try to give them the break between the NIVs. The duration can be gradually increased, and the patient could be weaned off gradually. So this was in short about the NIV. I am sure NIV is a huge topic, and we will have interesting discussion under the leadership of Professor Khilnani sir. So the most important thing is knowing about the indications and the contraindications for NIV. As I said, NIV is much more labor intensive as compared to intubation and mechanical ventilation, and one has to be really on the toes for the success of NIV. The most important determinant of NIV success is the patient's comfort, and we must make all our efforts to make our patient comfortable. And for that, the right interface is very important. Most of the time, it is the oronasal interface which is used. Intensive monitoring is required. Definitely, there's no doubt about it. And understanding waveforms is of utmost help if we are using any kind of ventilator, that needless to say. So thank you all for patient hearing, and thank you everyone for making me part of this webinar on this auspicious day where we have Navratris and Eids together. Thank you everyone.
Thank you, Dr. Gyanendra Agrawal, for that very precise overview of usage of NIV in acute settings, and that was a very comprehensive and concise description of the issue, and I'm sure we're going to learn much more during the discussion. So I have the pleasure of performing a very pleasurable duty of introducing our moderator and chairman, Professor Dr. G C Khilnani, who is the chairman of the PSRI Institute of Pulmonary Critical Care and Sleep Medicine. And formerly, we all know that he has been the professor and head of Department of Pulmonary Critical Care and Sleep Medicine at the prestigious All India Institute of Medical Sciences, New Delhi. Dr. Khilnani is an overseas fellow of the critical care at Mount Sinai Medical School, has been an ex-member of the executive committee of Indian Society of Critical Care Medicine, where he's very active, and most recently they've come up with guidelines for antibiotic usage in various ICUs. He is a fellow and global governor of the American College of Chest Physicians. He's been a fellow of the National Academy of Medical Sciences, is the zonal chairperson of the North Zone of the Indian Chest Society, and happens to be obviously a member of the governing council of the Indian Chest Society. He is the past president of the National College of Chest Physicians. He is a member of the technical advisory group of WHO Global Air Pollution and Health, and that is something that he has been championing as a cause for a long time. And we've been listening to his snippets on the social media, as well as his regular interactions on TV and for education of common masses. He is hugely published, has published more than 250 publications in national and international journals. Dr. Khilnani is a teacher for everybody. He keeps on summarizing various questions or various studies for easy understanding of most of the students and pulmonary physicians of the country. It's a pleasure to have him as moderator for this session. Over to Dr. Khilnani for moderation of the session, sir.
Thank you, Parvaiz, for a generous introduction and your kind words. More than what is written on this, it really pleases me coming from you. So, ladies and gentlemen, now we are in for a very vibrant discussion, and first and foremost, from all of us, more than 1,000 or maybe 1,500 people who are logged in, let us all wish Dr. Parvaiz a very, very happy Eid.
Thank
I'm
you very much, sir.
on half a kilo of food by now, and we're looking forward to leaving us soon. So, Dr. Parvaiz, besides being one of the dearest friends, he is one of the senior most internist as well as pulmonologist of this country, who has the credit of being the most important designation he has today is the editor in chief of our esteemed journal that of Indian Chess Society, that is Lung India, and he has taken that journal to a great heights, as we know that the impact factor has improved. But currently, he is professor and head of pulmonary as well as internal medicine at the iconic SKIMS, Srinagar, and he was director of the same institution. He is a fellow of Royal College of Physicians, London, and with more than 500 publications. And he has several, and of course, he is a member of the governing body of Indian Chess Society with several laurels to him. Uh, Dr. Parvaiz will have to leave, so we'll have him only for a short while in the beginning, and I'll take the privilege of asking few questions because he has to go into a celebration mode after this. We also have, of course, beside Dr. Gyanendra, Dr. Mansi Gupta, who is a DM Pulmonary Medicine and currently working as associate professor at the Department of Pulmonary Medicine at the SGPGI uh, Sanjay Gandhi Institute, Lucknow. We also have Dr. Priti Meshram, who is a professor and head of pulmonary medicine at the GGMC and JJ Hospital, Mumbai. She also has the privilege of being a fellow of Toronto Lung Transplantation Program. Beside this, we have Dr. Hariprasad, who is a consultant and faculty pulmonary and critical care medicine at the Apollo Hospital, Bangalore. He has interest in the interstitial lung disease, infections, and asthma, and has got several publications and book chapters, and he has been presenting at various conferences. So, with that brief introduction of my panelist, I'll start putting questions. So, as I said in my introduction, that NIV has come in a long way. As I said, almost in early 90s, when I first started using NIV, the brochure study came, which was published in New England Journal of Medicine, that he said that when you use NIV in patient with COPD, it improves the hospital stay as well as survival. And subsequently, with the progress of the machines and progress of the studies, we expanded the indications. Some of the indications which were was contraindications became into relative indications. Some of the things which were in class two indication came into class one. So Dr. Parvaiz has a long experience of using NIV in respiratory medicine. So Dr. Parvaiz, in your experience, how the indications of NIV have evolved over the years and what is the current status?
Thank you, Dr. Khilnani, for that generous introduction. And I must say, I mean, there has been a tectonic shift actually in the usage of non-invasive ventilation. And from our initial focus primarily targeted on restrictive conditions like sequelae of tuberculosis or poliomyelitis. And then at the study that you talked about, the NEGM study, where it was shown that it does help in hypercapnic respiratory failure associated with chronic obstructive lung disease, which used to be pretty much the only indication for using non-invasive ventilation. It has evolved in a big fashion from using it in an acute setting in, say, acute exacerbation of a chronic obstructive pulmonary disease or acute acute respiratory failure in any condition where you would want to avoid or prevent the introduction of a tube. And if you could safely do it in HDU or ICU settings, it has been used now, I mean, for increasingly for hypoxic respiratory failure, as Dr. Gyanendra talked about, cardiogenic pulmonary edema, it has been used. Then other indications like kyphoscoliosis or chest wall diseases leading to hypercapnic respiratory failure. And it has reduced the intubation rates, as you rightly said, that contraindications became indications. It was a clear no for all kinds of pneumonia for a long time, and we would say that whenever there is a patient of pneumonia, he has to go and require any kind of a ventilatory support. It has to be invasive ventilation. But then it evolved, and over a period of time it became clear to know people, especially in the COVID pandemic, it came to be known that people with viral pneumonia can actually there are lots of studies that have shown that non-invasive ventilation does actually help, even though there are differences of opinion for usage in COVID pneumonia. But nonetheless, there is a strong body of evidence to suggest, yes, non-invasive ventilation does help in COVID-19 pneumonia patients as well. So another indication that came up was to avoid ventilation or avoid intubation. And it has been advocated to prevent intubation and reintubation in patients displaying signs of respiratory distress even before intubation becomes necessary. And the evidence has actually been so much that most of the guidelines have actually included the NIV as a armamentarium for managing sick patients. And also, not only in the acute settings, we use them in patients with obstructive sleep apnea, in patients with chronic respiratory failure, chronic hypercapnic respiratory failure on a long-term basis as a part of the home rehabilitation or home ventilation facility. And not only have the indications diversified, as Dr. Gyanendra talked about, there have been technological advances. From interfaces have improved so much that they now focus more on patient comfort and adherence rather than just having something which is pitched. And it's very important that patient feels comfortable with the interface. So all in all, a lot has changed in non-invasive ventilation over a period of past few years. From indications, as you rightly said, that's something that was contraindicated some time back, has become more of a conditional recommendation or even a recommendation today. And there have been great advances in the technology associated with the various ventilators and the interfaces that have happened over time, and that has led to an increasing use of the non-invasive ventilation in today's time.
So, Parvaiz, if I could ask you a few things. What is your take on use of NIV in three conditions I am asking you? One is obesity hypoventilation syndrome. Second is acute severe asthma. And third is interstitial lung disease. If you could, because these are the different issues that we come across.
So again, obesity and hyperventilation syndrome, if you have a chronic we have in these patients also a chronic respiratory failure in chronic conditions. It has been used, and there are studies which have shown that it is used for asthma again and interstitial lung disease. The evidence is not definite. There is no doubt that there is no evidence, and it is only a very conditional recommendation for use in asthma as well as in interstitial lung disease, not a first or a routine use.
So, if I could add to that, Parvaiz, in obesity hypoventilation syndrome and acute respiratory failure, the use of NIV is a class 1 recommendation.
Absolutely.
One. Second is that if the patient is not in acute respiratory failure, the evidence says that CPAP, continuous positive airway pressure, it should be the first line of treatment and not the NIV. CPAP we don't call NIV. So although the everybody thinks that the CO2 is high, you start using bilevel positive airway pressure, but actually if it's not an acute condition, then CPAP should be used, and only if CPAP fails, then NIV should be considered. That is one. As far as the uh, interstitial lung disease is concerned, as you rightly said, that it is not a class 1 recommendation, but one indication that is used is as a bridge to lung transplant.
Okay.
To lung transplantation. If the patient is awaiting lung transplantation, you don't want to intubate this patient because he sort of become less fit for lung transplantation. So all efforts should be made to manage this patient with NIV. Otherwise, there is no survival benefit when you use. And also, when is what we call as not to intubate. Instructions are there, or the advice is there from the family in the interstitial lung disease. Then we use non-invasive ventilation. So.
So may I interject and ask you? I mean, would you in today's time say that CPAP is a form of NIV, or you would say that it is not? Because there's a lot of difference of opinion on that.
As far
Lots
as
of people say that it is a form of NIV.
No, CPAP is not considered a form of NIV.
Okay.
That is semantics. Semantics for the purpose of
Semantics.
discussion. Otherwise, there are machines. If you have a bilevel positive BiPAP machine, you can use it as CPAP machine. And
True.
course, that is there. And so, since you have to leave, so I'll ask you one more question, if you can permit me. Although this question was to come later, that and this question is a little tricky. And when should you repeat ABG, and how should we change setting based on the ABG?
I think Dr. Gyanendra very nicely said that when do you
But,
have yes, I
Dr.
mean,
Amita, I said in the beginning, even if you have it has been discussed, you have to again.
go on repeat. So yes, I mean, issue is that whenever you put a patient, for example, you have a acute hypercapnic respiratory failure on put on NIV, you have to assess first, and the most important thing that BP do not talk about is the patient comfort. And that is something that dyspnea, the clinical condition of the patient, and that is something that you need to look at: the respiratory rate, the dyspnea, the patient comfort, especially whether he is struggling with the interface. And then specifically also we have to see whether he's comfortable or he's getting more agitated in terms of his consciousness. And if he is deteriorating, then it may be a sign that your NIV is going to fail. Talking about the specific lab parameters, when we talk about the ABGs, it is recommended that after about an hour of starting the person on an NIV, you repeat the gases, the ABGs, and find out what is happening to them. If they are improving, then you can repeat them after every 2 to 3 hours. If they are not, then you have to change the settings, and depending on what is the ABG, then you go on changing the settings. That is what I would say, that you do it after an hour, and after that every 2 to 3 hours.
So, so the study that I had the pleasure of publishing, almost the first randomized trial from this part of the world, when we conducted a study on randomized trial of NIV in COPD at the All India Institute of Medical Sciences. Dr. Sekia, Nripen Sekia was my MD student who actually did that. And in that study, the mean PCO2 was 82.3, and then mean pH was 7.1. And that time it was not a recommendation, when in those days I've lived through NIV, so I can quote the timing and all. So at that time, the pH less than 7.1 was a contraindication, absolute contraindication to use NIV. But we conducted this study. Why I'm telling you is not to say what I've done, In that study, we did ABG at the outset, then after 1 hour, then at 6 hours, and then daily. Now, I'm not saying that that's the most appropriate way of doing it, but ABG is something, which is a little expensive, may not be available everywhere. And subsequently, uh, so Dr. Gyanendra said that, you can use the NIV in a patient with coma. Sorry, I beg to differ, Gyanendra. If the person is comatose, you should never use NIV. What recommendation is that the patient has altered level of consciousness and patient has COPD, not the comatose. If the patient is in proper coma, then you cannot use NIV.
Yes, that
What
stands as a
recommended?
contraindication.
What recommendations say that if there is an altered level of consciousness only with the COPD, then you can use NIV for 30 to 60 minutes and watch very closely for the improvement. And B, you should have a low threshold for intubating them. Don't let the patient crash, because studies have shown that the level of consciousness improves over a period of 30 to 60 minutes, and then you can uh, continue with the NIV. And then is a very nicely one line he said that if you, and which I keep reciting, that if you intubate a patient, you can put a setting on SIME or whatever and go for a cup of tea, nothing will happen to the patient. But if you are treating a patient with NIV, you have to actually be there and monitor for leak and response and his comfort, oxygenation, and so on and so forth. So, Dr. Parvaiz, happy Eid and thank you very much. I
Thank
allow
you
you
so much.
to leave and be with your family and friends.
Thank you
And
so much, sir.
it's
And
only
thanks for the
your
opportunity.
commitment for the academics and pressure from Amita that you are here.
Thank you so much, sir.
But, thank you. Thank
Thank you,
you.
sir.
So,
Thank
ladies
you
and
so much.
gentlemen, we go ahead with our discussion, thanking profusely Dr. Parvez for being there for us. So, Dr. Preeti, if I could ask you, in your experience, what are the contraindications? Dr. Preeti, please. Dr. Preeti, can you hear me? Dr. Preeti is there?
Yes, sir. Yeah, yeah. Can you hear me now?
Yeah, of course I can. Did
Yeah.
you get my question?
Yes, sir, I did. At
Yeah.
the outset, good evening, sir. And thank you and thanks, Dr. Amita, for giving me this opportunity. So, regarding the contraindications, we've already had a presentation by Dr. Gupta. So, by Dr. Gyanendra. So, I just repeat what he has said. So, the absolute contraindication would definitely be an impending respiratory arrest where you know that the NIV is not going to work, where you know that there is a need for immediate intubation. Patients who have facial traumas, patients who have facial surgeries, burns, or any facial abnormalities that would cause a misfitting of the mask. You know that when the mask is not a proper fit, there's not going to be a proper delivery, there's going to be some sort of air leak, and it's not going to be very effective. Patients who are having a lot of vomiting, patients.
Dr. Preeti,
Hello?
interrupt you. Is
Hello?
edentulous patient is a contraindication?
Sir?
Edentulous patient who doesn't have teeth.
So if the face mask, so it would again, sir, it would cause a lot of leaks. So that would again be a relative contraindication.
Relatively. Okay, please go ahead.
So then apart from that, patients who have a lot of vomiting, patients who have GI bleeds, again, we would not recommend NIVs in those patients. Patients who, sir, just now said patients who are comatose, patients who are not able to protect their airways, patients who have a low GCS, a GCS of less than 10, again, would be contraindications for starting NIV. Patients who have, hemodynamic instability, definitely a contraindication for starting NIV. So this would be a rough list in whom you would not consider giving NIVs.
Okay. And of course, the patient who have got PF ratio of less than 150,
150, yeah, that would, yeah.
yes, the NIV should not be tried. The experience of majority of experts in our country and outside during COVID pandemic was that when there was overzealous use of NIV, thinking that patient is still maintaining oxygenation but he was deteriorating. There were more mortality in patients where NIV was used as compared to the patients who had early or timely intubation. So therefore, it's critical to have a clinical judgment on the use of NIV, especially in acute hypoxemic respiratory failure, whether you call it acute lung injury or ARDS. So thank you, Dr. Preeti, for this amazing to the point answer. And now I come to Dr. Mansi. Uh, the question is, how do you use different kind of masks in different settings? If you look at the mask, uh, plethora is increasing. Nasal. The brochure study in 1993 was used only with the nasal mask, and then came oronasal mask, then facial mask, and then nasal pillows, and in something which goes only into the mouth, and then helmet. So, Dr. Mansi, please tell us, how would you use different kind of masks?
Thank you for the question, sir. Am I audible enough?
Yeah, well, very well.
So, as sir has already elaborated on the types of available masks, so there are two things I want to stress upon. Mask or the interface, as we call it, they are the most important things when you're going to ventilate your patients with NIV, because that is going to decide on lot of troubleshooting things that we are going to discuss later on. And the other thing is that we have to understand that no mask can be specifically good for a patient. You have to have the whole assortment ready for the patient, as they have to be used interchangeably in clinical practice at times. So when we talk of the types of masks, there are nasal masks. So you have nasal mask and nasal pillow. Then you have a mask which will cover your nose as well as your mouth, which is known as the oronasal mask or orofacial mask. The third thing which is available to us is total face mask, which will cover the entire face through your forehead, and it will also cover your cheeks and the other areas. The next mask, or the most important one, which is being talked about these days, is the helmet device. Now, when we talk of nasal masks, the most important thing to remember is that they are not made for acute care settings. They are made for chronic care settings. The primary reason for that, as you can all think with your own common sense, that when you're using something in the nose and you're pressurizing the airway through the nose, if the patient is mouth breathing at any point of time, there will be leak through the oral cavity, and your NIV will be ineffective. Absolutely. Obviously, the patient is more comfortable with nasal masks and pillows. So, in patients who are used to receiving therapy in chronic care, they can be more comfortable with nasal mask, but again, in acute setting, they would require an oronasal mask. Now, oronasal mask is the most preferred one because of the ease of availability, the cost factor, and it is most people are used to how to use the mask. So that is the most commonly used mask, almost in 70 to 80% acute care settings. The major advantage is that you don't have any leak around the mouth, and it provides least dead space. So what is the concept of dead space? Because you want to wash out CO2 in hypercapnic respiratory failure. So amongst the available masks, amongst orofacial, total face, and helmet device, this is the mask which provides the least dead space. Again, it is less claustrophobic for the patient also, because you're not covering the entire face of the patient. The problem is that the patient is not able to speak, is likely to aspirate. So those are the problems with these kind of masks. And there's a lot of leak around the eyes. And there can be facial necrosis around the nasal bridge. So this is a disadvantage. Coming to total face and helmet masks. So these are the masks which have been popularized recently because of the patient comfort and acceptance towards these masks. And they have also been shown that their efficacy as compared to oronasal mask, even in type 2 respiratory failure, despite being touted as increase in dead space, is not that bad. So you are getting better patient comfort, but not at the cost of ventilation. So obviously, in right settings, the clinician can choose total face mask and helmet devices. The issue with these masks is again the dead space. So you need higher inspiratory pressures or higher flows to maintain the flow in the circuit. And the helmet device per se can be a bit noisy for the patient at times, what we have seen in our practice. But again, it is very effective in patients who are in moderate to mild acute hypoxemic respiratory failure. So this would be my choice of available mask, sir.
Thank you, Dr. Mansi, for clarifying. So I'll give some comments on that, because the brochure, when he did that study, he used nasal mask. And the study that I quoted, that with the PCO2 of 82, in which within an 1 hour the pH significantly dropped and the CO2 significantly increased. We use nasal mask. And if you review the meta-analysis of NIV in COPD, out of 7 positive studies, 3 studies were conducted with the nasal mask. So if you talk about rapidity of correction of respiratory failure, that oronasal mask is much better than the nasal mask. There's no questions about it. Why I'm bringing up this issue is that if some patient is unable to tolerate oronasal mask because of being claustrophobic or because of whatever reason, don't dump nasal mask. It can be used in acute respiratory failure, especially in COPD, because you don't require too high pressures as compared to the hypoxemic failure or ARDS. So I totally agree with you that oronasal mask is the preferred one because it in acute setting, because it gives to the rapid correction of the. This is the evidence that the correction of acid base and gases is much faster with the oronasal mask, and of course the nasal mask is preferred for chronic respiratory setting. Regarding helmet is an Italian invention, and Italians are very fond of it. But there's the Chicago study you must have gone through, which actually it was a randomized study on 88 patients, which clearly showed that the helmet works very well. I think it was Bhakti Patel's study with John Kress as a lead person. This worked very well, the helmet mask. But somehow the helmet has not taken over as a. I use it for, like, we have a Sikh population in northern India who don't want their beard cut, and then you can't use effectively oronasal mask. Sometimes I use helmet mask because that circumvents the problem of beard. That, of course, anecdotal. There's no study to prove that. So thank you, Dr. Mansi. That was amazing answer. I have no experience of using full face mask because I think the oronasal mask suffices. And you have beautifully talked about leaks. So now I come to Dr. Hari. What are the settings to be kept when starting an IV in a new patient, and how would you subsequently adjust this setting when the patient is settled? Dr. Hari, please.
Yeah, good afternoon, sir. Thank you for the opportunity for having me here. So the first thing that we need to notice or we need to be careful when we start a BiPAP is that we start slowly. We start at a lower pressure, make the patient comfortable, and slowly increase the pressures as we see the patient becomes comfortable. So normally in the ICU setting or an ER setting, we would probably start with a bilevel, non-invasive ventilator and start with an IPAP of somewhere close to 8 to 12 centimeter of water. The IPAP basically determines how much tidal volume the patient is going to get, and usually the EPAP determines the level of saturation. So EPAP is more like the PEEP that we have on the ventilators. So for a patient who comes to the ER, I would probably start the IPAP at a setting of say 8 to 12 and start the EPAP at probably somewhere around 3 to 5. Now then slowly I titrate to the patient's level of comfort. I see for certain objective parameters, say the respiratory rate comes down, the work of breathing is better, the respiratory muscles are slowing down. And then I can adjust so that I get a tidal volume of say 6 to 8 ml per kg. I see that the respiratory rate has gone below 30. So once I get that, I set the IPAP there. EPAP we can slowly increase according to the desired saturation. So EPAP determines how much saturation we get. So slowly going up from 3, 4, 5 and slowly increasing it up to a maximum of 10. But we have to be careful that the difference between the EPAP and the IPAP is basically the pressure support. So the difference between the two is the pressure support, which actually determines the tidal volume. And also we make sure that the IPAP doesn't go beyond 20 because that is the pressure at which your lower esophageal sphincter opens up. And so if you require an IPAP beyond 20, probably the patient should be on an invasive ventilator. So starting EPAP probably around 3 to 5, starting IPAP probably between 8 to 12, titrate slowly to reach these settings which I mentioned, which is a respiratory rate less than 30 and a tidal volume titrate to around 6 to 8.
So thank you, Hari. But my question to you is that you said that EPAP is given for maintaining the oxygenation as we do in ARDS and acute lung injury. But in the patient with COPD, the philosophy or the physiological basis of giving EPAP is counteracting the intrinsic PEEP.
Exactly, sir.
Because in COPD, maintaining oxygenation sometimes is not a problem. Even if you give nasal prongs, we give BiPAP, bi-level pressure, because they are in type 2 respiratory failure with CO2 rising and pH dropping. In that case, how do you use your EPAP? You suppose the oxygenation is normal. So how do you maintain uh, EPAP? How do you discern that EPAP should be 4 or 6 or 8 or 10?
So in a COPD patient, if I'm using EPAP, it is most often to overcome the intrinsic PEEP or the dynamic hyperinflation that happens in this patient. So if we have a proper ICU ventilator, we can look at certain parameters, the level of expiratory airflow limitation. We can titrate and then try to increase the EPAP slightly so that you overcome this dynamic hyperinflation that happens. But again, the same thing holds true here. You can't increase it beyond a certain limit in COPD. So I probably, just enough EPAP to overcome the dynamic hyperinflation, but not too much that it just causes too much of obstruction there.
So if I could add to that, Dr. Hari, that when you give titrating the EPAP in a patient with COPD, you start with, as you rightly said, start with 4 and keep on increasing by the fraction of 2 centimeter of water, and look at the ease of triggering. How the patient, if your EPAP is too low, then patient will be putting lot of efforts in triggering the ventilator to counteract the dynamic hyperinflation. Then you would see his accessory muscles working very hard, and that includes the abdominal muscles. So it's a totally clinical decision looking at it. And as you said, the critical care ventilator is much better for that, because you can see the graphics. And when at whatever level, it could be 8 centimeter or 10 centimeter of water, that you see that patient is now able to trigger the ventilator each breath, and his accessory muscles are quite in comfort zone. That's the way I use it. And if you agree with me, and if you have some more comments on that. Another thing I want to comment, that while using NIV for acute respiratory failure, the critical care ventilator, in my experience, give better results than the portable ventilator. Do you agree with that?
I do agree with that, sir. The only drawback I have seen is probably with the leaks. I have seen that the portable ventilators are a little bit more comfortable. They tolerate the leaks a little better than the ICU ventilators.
Compensation. And for the people who are learning, it is important to say, when you want to give ventilation of 16 and 8, you have to put on critical ventilator 8 plus 8, not 16 plus 8. On a portable ventilator, you will put 16 plus 8. Do you agree with that?
Definitely.
This 8 centimeters is above PEEP, whereas in small portable ventilator, the IPAP, you have to give it 16, and the EPAP. This is the setting problem. So thank you very much, Dr. Hari, for this absolutely perfect reply to this query. And now I come to Dr. Priti again. Dr. Priti, what kind of alarms you would keep on NIV, and tell us both about portable ventilator as well as critical care ventilators, because those are different. Dr. Priti, can you hear us?
Yeah, I'll just unmute myself. Sir, can you? Yeah.
Yeah.
So,
Did you hear
yeah.
my question?
Yeah, sir. I would.
Yeah.
So,
All right.
so most importantly would be the circuit disconnect alarms. Maybe, that would be one of the most important, to keep an alarm of around 30 seconds or so. An apnea alarm, also a tidal volume. So basically there would be volume alarms, there would be pressure alarms. So basically a low pressure alarm, to detect if there has been any disconnection, or if there has been excessive leakage. So that would, those kind of alarms, or high pressure alarms again, so in which the patient is also spontaneously breathing, plus the patient, plus the ventilator is also giving the breath. So, that would predispose to developing barotrauma. So a high pressure alarm, respiratory rate alarms, again, a low respiratory. So it is the ST mode. So a low, again, a respiratory rate alarm, a high respiratory alarm of around 30, a low respiratory alarm of 10. A low inspiratory pressure alarms are somewhere between the IPAP and the EPAP, so that we know that, the required pressure is being maintained and delivered. So roughly these would be the so again, these alarms would depend on the patient's body weight, the patient's respiratory rate, especially the apnea rate alarm. So if whatever is the patient's respiratory rate, maybe we can just keep half of that. So depending upon patient to patient, we can keep this alarm, sir.
Okay. Thank you. Thank you, Dr. Priti. I come to Dr. Mansi again. Tell us about troubleshooting and how would you manage? What are the situations which you come across where you have to come in and troubleshoot the non-invasive ventilation?
So, when we are actually using non-invasive ventilation, we have to look for four important things in troubleshooting. One is the mask-related problems which the patient is going to have because of the interfaces that we have chosen. The other problem is not able to achieve the required blood gases, especially there is a problem of CO2 not improving or CO2 rebreathing. The third thing that you have to look into is leaks, the problems of leaks. And the fourth thing is patient not being able to synchronize with the ventilator, or all we call it as patient ventilator asynchrony. So, for the problem of mask-related issues, Dr. Gyanendra has very well covered in the talk that you have to select the patient's size appropriately. You have to use cushioned masks. You have to actually measure for patients' facial anatomy so that you don't land up into mask-related issues. You have to give mask-free time to the patients, and if you possibly can, allow for 2 hours intermittently during the time so that there is no pressure necrosis over the nose nasal bridge. You should use more assortment of your masks, as we have already discussed. So these are the mask related issues. The major issue with another issue with masks is there is a lot of nasal congestion, gastric insufflation, the kind of pressures that you are using. So all those things have to be looked into with their required settings. The second thing that I was speaking about was the problem of CO2 rebreathing. So now we have to understand the concept of vented and non-vented masks. So when we are using the critical care ventilators, which are dual limb ventilators, you have a separate limb for inspiration and separate limb for expiration. So you have to use a non-vented mask because there is an active exhalation happening through the dual limb. But when you're using a single limb circuit, like in a portable ventilator or in ventilators in ICU also, where you have a single limb ventilator designed specially for NIV, you have to use a active exhalation port in the limb, single limb. Now, the placement of that port, exhalation port, should be as close to the mask as possible. Otherwise, there will be issue of CO2 rebreathing. And the other thing that you have to make sure, obviously, we have heard it before, that the FiO2 should not be very high, your IPAP settings should be good, and you should not have additional dead space in your circuit so that your CO2 rebreathing doesn't happen. The third problem that I was speaking about was the leak problem. So leak, I have said that choosing the right mask is the best thing that you can do. But I want to point out one thing, that to prevent leaks, do not tighten your mask absolutely too tight. It actually increases the leak if you are tightening the mask too hard. So there's a two-finger rule that we follow in our ICU, where you have to insert 2 fingers. It should be easily inserted in the headgear, and that should allow that movement of mask to happen, because there's a good cushion around the mask to prevent the leak. So leak should be absolutely avoided as far as possible, because the last problem in troubleshooting is related to leak a lot. That is the problem of asynchrony. So asynchrony is basically a very wide topic. I'll just briefly touch upon it by saying that your leak is the main factor behind a lot of asynchrony issues. The mask also again plays a role, and there are two types Dr. Gyanendra has already pointed out. There's a triggering asynchrony and there's a cycling asynchrony. So in settings, you have to select for flow trigger settings, which are more comfortable and better synchronized in most patients, and especially COPD patients also, in terms of not promoting auto peep development and decreasing the inspiratory effort. Lot of factors there. So that is about troubleshooting. I may have missed a couple of points. Maybe sir would like to add upon them, sir.
Yeah, I want to tell her. Suppose you have started NIV and on with a critical care ventilator, and patient is not able to trigger. What will you do?
So, inability to trigger is because basically one thing is patient-related issue. If we are dealing with a COPD patient, is sort of got overinflated lungs and auto PEEP. That is one of the commonest problems, that patient is not able to trigger well. So you have to adequately set your PEEP settings. The second thing is you have made your trigger settings way too insensitive for the patient to be able to generate a breath. So your trigger settings should not be that strong for the patient to be able to initiate a breath, because ultimately is going to take a breath from the ongoing flow in the circuit. And obviously your flows should be adequate so that patient can actually generate a good breath. So these are the most important parts of ineffective triggering.
Dr. Mansi, especially in a patient with COPD where there's intrinsic PEEP, which you cannot measure in a patient who is not on ventilator, then one of the common cause of inability of triggering is too high intrinsic PEEP and too low EPAP.
Yes, sir.
So the patient has to generate. Suppose you have kept a pressure of triggering of 2 centimeter of pressure trigger, and he has an intrinsic PEEP of say 8 centimeter or 10 centimeter, and you have kept a PEEP of 6, then he has to generate 6 centimeter of pressure or flow or whatever. So therefore, in especially COPD patients, it is very important to discern that intrinsic PEEP. The PEEP should be commensurate with the intrinsic PEEP, which can only be known clinically by looking at their
Yes.
accessory
Their breathing pattern, and yes.
breathing part and use of accessory muscles, and also looking at the graphics, which is the next question to Dr. Hari. If you are using a critical care ventilator, you will be able to make out that there is a leak or there is a intrinsic PEEP which needs to be countered. So thank you, Mansi. Very excellent description of the asynchrony and troubleshooting. I come to Dr. Hari, now this question is very difficult to answer verbally. That how to read graphs in NIV, unless you actually have a PowerPoint. But Dr. Hari, please use your oratory skills to tell us how to
Yeah.
graph. This question is from Amita. No, I have not made it.
So we are all used to seeing most of the ventilator graphics in an intubated patient rather than in a non-intubated patient. So, the graphs, we can only read it off a critical care ventilator because the smaller portable ventilators don't have as good graphs as your, the ventilator or the invasive ventilators there. So what I would usually look on a patient on NIV, on a critical care ventilator, the few things I usually notice on the graphs is one is the leaks. So because this is very important, except for, probably a NAVA ventilator where the ventilator compensates for the leaks, all the other ventilators you can actually read out through the volume and the graphic, the flow curves. So normally when you have a flow time graph there, you can see that the area under the flow time between the inspiratory and the expiratory flows should be roughly equal there. And if you see there is a lot of disparity or difference between the two, that means that there is a leak happening through somewhere, either the mask or the systems or somewhere. And also you can see the volume time graph where you can see an abrupt cutoff of the volume graph, which shows that some air is being leaked out through the system. The other thing is if you set a certain pressure, the pressure is not rising to that particular set pressure. That also means that the system is leaking air, or the pressurization is not happening adequately. So this is one of the most important things to look for leaks there, either through the flow volume or flow time graph or the volume graphs there. The second things, the other thing you can look at is the oscillations that you see in the flow curve. This can also happen if you have some, leak, as well as some. One of the common things that I see is you use a humidifier, the water condensates inside the limbs, and then you can have slight oscillations on the flow curve. The other thing I would probably look at is the auto trigger. Now, auto trigger again happens when the ventilator triggers, or ventilator provides the breath when the patient is not triggering it. So this happens when there is a leak, because most of the ventilators are flow triggered. And when there is a leak happening somewhere, and if this is more than the trigger threshold, the ventilator will naturally provide a breath. So auto triggering happens when you have a leak there, or sometimes even water in the limbs can also cause an auto triggering. Now, the reason this is important is all this leads to asynchrony and desynchrony with the patient, and it makes the patient uncomfortable. You don't want to have the machine delivering a breath on your face when you're not asking for it. And sometimes these auto-triggered breaths can come in, quick succession, and that will be even more discomforting for the patient. The other thing is the opposite of this, which is called as double triggering, when the patient has a very high inspiratory drive. So what happens is that the patient triggers the ventilator very quickly, successively. So, you get a large volume, but you don't have enough time to have for expiration. So this is called as double triggering. And then you have something called as ineffective respiratory efforts, where you see the patient has generated as pressure. There is a deflection in the flow curve, but this has not translated into the ventilator providing a breath. Now, this happens if the efforts are very less. The patient is probably fatigued, or the sensitivity has been kept high, so that the ventilator is just not being triggered to provide a breath for the patient. The other ones are usually the early and delayed cycling. Now, whenever a breath is provided to a patient, there is a certain parameter set which tells the ventilator that, you need to stop inspiration and go into expiration. So in many of the ventilators, you can see it as an ETS, or expiratory trigger sensitivity. So now what we do is, in some patients, say COPD patients, we usually keep it somewhere around 40-45%. And in patients who have hypoxemic respiratory failure, or ARDS, you keep it a little on the lower side. Now, sometimes you have something called as early cycling, where the patient's inspiratory effort is prolonged past the cycle event. So what you usually see is that the airway pressure will fall below the PEEP before the start of expiration. Now, unless we see the graphs, we will not be able to make this out, because these are a little, once you see that, you're not going to forget it either. So these are the early and the delayed cycling. You can always tinker with the ETS, and you can figure out where the patient is comfortable with this. So these are some of the things which I usually see.
Dr. Hari, I must compliment you. It's very difficult to discuss all these things without the help of PowerPoint or graphics, but you have beautifully done that actually. And anybody can understand about double triggering that you talked about, the effect of leak and, and intrinsic PEEP. When the leak is there, the flow will be there prolonged, and it will never come to baseline. So thank you so much. So Dr. Gyanendra, I hope you had sufficient rest after your astute deliberation. So now question comes to you. What initial setting would you like to keep in patient with ARDS? Also, please include in your answers uh, uh, cardiogenic pulmonary edema.
Okay, sir, most of the points are already covered. So ARDS, one should be very careful when we are using NIV. So I repeat when I said earlier also that in severe ARDS, especially if the PF ratio is 150, less than 150, one may not use NIV. If we are using NIV in early ARDS, then it is better to use with the bilevel mode. The initial pressure setting could be like IPAP of 8 and EPAP of 4, and then we can gradually increase the IPAP and EPAP settings every 20 to 30 minutes, depending on the patient's response and the other vital parameters which we monitor. So if the patient is having hypercapnia, we need to increase IPAP. If the patient is having primarily hypoxemia, we need to increase the EPAP. The maximum IPAP could be up to 20 to 25 centimeters of water, whereas EPAP could be 10 to 15 centimeters of water. The backup respiratory rate again is around 12 to 16. If the patient is not triggering, if there are large air leaks leading to autocycling, one may switch to pressure control mode also in NIVs, particularly with the critical care ventilators. The challenge of using NIV in ARDS patients is to limit the tidal volume, which is really difficult. And this is one big problem which leads to failure of NIV in ARDS patients. Now, as far as the cardiogenic pulmonary edema is concerned, the preferred mode initially is always CPAP, and majority of the patients will do well on the CPAP mode. Again, the CPAP could start from 4 and then 5 centimeters of water, and then gradually it may be increased. But if the patient is not responding well on CPAP alone, and if the patient is developing hypercapnia on CPAP, along with signs of respiratory failure, then one may switch over to the BPAP or the bilevel. The settings and all would be mostly similar, and the principles of management would be mostly similar in the cardiogenic pulmonary edema also.
So, thank you. Thank you. You have been very brief and to the point. But I wanted to emphasize this point. Everybody thinks that if there's a cardiogenic pulmonary edema, jump to BiPAP, because they think more the merry. The evidence shows that CPAP is as good as BiPAP, unless you have hypercapnia, as Gyanendra said, that if there is a hypercapnia or there is a suspicion of coexisting COPD, because medicine doesn't go mathematically, you have to use your judgment. So many patients with cardiogenic pulmonary edema have underlying COPD, or they are obese, they have element of obesity hypoventilation syndrome also. There you may use your clinical judgment and go for BiPAP straight away. Otherwise, in a garden variety cardiogenic pulmonary edema, CPAP should be used and BiPAP should be reserved if it doesn't respond or the CO2 starts rising. So I come to there was a question for Dr. Parvaiz, NIV setting to initially keep in COPD. This I think we have discussed number of times. I need not go into this. I thought I'll answer that, but I have answered that in between. So I'll come to Dr. Priti. It's going to be rapid fire because we have to finish by 10 o'clock and take some questions for 10-15 minutes. So what is NIV protocol for pneumothorax and pneumomediastinum patients? We saw a lot during the COVID pandemic. Dr. Priti, please, if you could briefly answer.
If the patient is having a pneumothorax, the first thing would be to actually drain the pneumothorax, put in an ICD. Pneumomediastinum usually, so most of these things are caused by patient self-induced lung injury when the patient is trying to breathe himself and the ventilator is also trying to give a breath. So there are large volumes and there's increased pressure which causes the barotrauma and subsequently pneumomediastinum and pneumothorax. For pneumothorax, definitely drain the ICD, drain with an ICD, set the pressures at slightly lower levels, especially if there is a PEEP, you decrease the PEEP. We can reduce the tidal volume so that the effect of barotrauma is less. If the patient is hypoxic, if the indication for NIV is only pure hypoxia, then maybe we shift the patient to high flow oxygen therapy. If the patient is a case of COPD and is requiring NIV and has developed a pneumothorax after putting in an ICD, then maybe we decrease the PEEP, decrease the EPAP, allow for permissive hypercapnia, even if the patients in COPD usually, as you said, sir, or get oxygenated very well. There's no problem of oxygenation. The problem is CO2. So we can allow a permissive hypercapnia, allow pH of around 7.2. If despite that the patient is not getting, the patient not getting better in terms of CO2, then we may think of intubating the patient, which would give a better control. So basically, it would be decreasing, taking all measures to reduce the pressures. If the patient has tension pneumomediastinum, then that is a problem. Then we need to surgically drain the pneumomediastinum along with taking all these lung protective strategies. And surgically drain the pneumomediastinum. So tension pneumothorax and tension pneumomediastinum are the only two problems. Otherwise, by lowering the ventilatory strategies or providing lung protective ventilation, we should be able to manage the patients.
So, Dr. Priti, one of the problem is when you have a bronchopleural fistula also.
Fistula.
So then of course it becomes very difficult.
So then, so what we can do is, maybe if the leak is very large, then again, sir, I mean, we've tried this in our set of patients where if the leak is very large, then probably it becomes difficult managing with NIV. Then, and if the patient is continuing to retain a lot of CO2,
what you want to say that
we can produce single lung method
as low as possible and practice your all skill permissive hypercapnia and also that you don't cause more damage. So, Dr. Mansi, I come back to you. We usually use pressure support ventilation. Are there any other modes which can be used with NIV and in what conditions?
So again, I will like to emphasize, sir, that the pressure support is the most important mode that residents should be well versed with. But having said so, there are newer modes which are coming up. The most commonly asked modes by the residents is there is this AVAPS mode, which is volume assured pressure support, automated volume assured pressure support. This is again, all these newer modes have not been, they are still under evolution. There is no strong evidence to suggest that they are better than pressure support mode in terms of ventilation or the hospital stay or even the mortality. But however, most of these modes are targeting the major point of the target is patient ventilator synchrony and better adaptation to the ventilator. So in AVAPS, you are combining two modes. You are getting the benefit of pressure support ventilation as well as you're trying to assure the volume delivered, which cannot be assured in pressure support usually if there are too many leaks. So
which condition you will use?
So in severe restrictive conditions where you have a lot of chest wall problems or severe obesity, that is one likely indication where you should use it. But again, it is not that pressure support will not work in such patients.
Evidence is not there. We actually very, very rarely use other than pressure support ventilation.
And other modes are there is a proportional assist ventilation, there is NAVA which is coming up, and there is adaptive servo ventilation. So again, they are for
not a separate mode. It is
it's just an evolution of pressure support only, just to synchronize the patient's breath better with the ventilator. Yes, sir.
Or faster triggering, Okay.
Just to add to that, sir, my thesis was on adaptive support ventilation from PG, and we had shown that there is no difference in COPD acute exacerbations managed by.
So thank you. So next question is to you only. What about proning?
So proning is a very controversial topic in non-invasive ventilation.
Because we need to finish.
Yeah, so before the COVID-19, we didn't have much of these prone NIVs, although we had a lot of prone invasive ventilators. During COVID, we have a couple of trials, although not of really good quality, where they showed that you can improve the oxygenation, you can probably reduce the inflammatory markers. But at the end of the studies, most of the trials have shown that you don't have much of a difference in the mortality. So, it is just an open-end question whether you can use it or not. And after the COVID epidemic was over and the studies have basically pelted out. So probably the usage of prone non-invasive probably would be the first 1 or 2, 3, was to 1 to 3 days of viral pneumonia where you are looking at and nothing beyond that. It's just uncharted territory, I would say.
So, Dr. Gyanendra, do you want to tell us something more about complication than you have already told us, or we go ahead?
Yeah, so sir, the commonest complications are the pressure sores, which I am actually really worried when the patient gets it. So nasal bridge redness or ulceration. So obviously we can choose the right interface and adjust it rightly to decrease the chances. Second one, sometimes the patient do complain of gastric distension and aerophagia. So we can always use lowest effective pressures, and one might use prokinetics, and sometimes they require nasogastric tube to be inserted for that. Nasal oral dryness is one common problem which the patient do complain, and we can always reduce that with the adequate humidification. And sometimes the patient may actually go into altered sensorium if they are not properly monitored, and they might aspirate with the NIV. Mucus plugging can also occur because of poor hydration, and adequate humidification and addition of mucolytics may help in reduction of those. eye irritation because of excessive leaks in and around the mask could be a problem for the patient, and we must try our efforts to reduce those things.
Okay.
So these are few things which, yeah.
So, Dr. Mansi, what about bronchoscopy?
So, in ICU setting, in patients who are hypoxic and they have respiratory distress, and there we need to do bronchoscopy. Suppose in a patient example, I'm giving that immunocompromised patients where we are not intubating, but we need to do sampling. So we are doing bronchoscopy with NIV support in those patients. And there are special masks which are available. It does ease out the work of breathing and doesn't allow, hypoxemia to occur. So they are very useful that way.
Okay. So, thank you so much for that brief answer. So, Dr. Priti, how do you choose between HFNC and NIV in patient with hypoxemic respiratory failure? Please, a short answer.
So basically, if it is so NIV offsets the work of breathing. HFNO is a more comfortable mode of delivering oxygen, in where it is at proper temperature and it is humidified, so the patient is more comfortable. So maybe type 1 respiratory failures, I would go for HFNO. Type 2 respiratory failures, I would go for NIV. So that would be the rough distinction of kind of using. But there have been studies.
You are dumping the NIV for hypoxemic respiratory failure completely.
So sir, not completely, but if you have underlying, lung injuries, ARDS, in certain ARDS, we would still go, but some amount of pressures are also given by HFNO, sir. Up to 4 to 5 centimeters of water, they still give, and they're more comfortable, sir. And even in studies of, even in COPDs, they have shown that even HFNO with those low pressure, especially in moderate type 2 respiratory failure, sir, where the pH is more than 7.2, there is a PCO2 of around 60. Even HFNO is useful even in those set of patients as well. So maybe very severe COPDs, type 2 respiratory failures, maybe I'll go for NIV. So NIV is not usually well tolerated given the mask and all that stuff. Even in my settings, I feel that HFNO is much better tolerated, so I would always prefer
if I could add to that, Priti, if you don't mind,
Yes, sir, sure.
In COPD, no question of using HFNC, and that is one thing. In COPD type 2 respiratory failure, the choice would be
NIV.
It is the only question of hypoxemic respiratory failure, and COVID taught us a lot.
Yeah.
So initially we were wary of using NIV. We thought that COVID will spread to the ICU and all. So we started using HFNC because hypoxemia was the primary pathology. Then these patients were getting tired and their CO2 started rising. So we started using NIV also. So in the end, when I was writing a lot and doing a lot of webinars and speaking a lot, so ultimately what I realized that we could use HFNC and NIV alternately. It could be complementary rather than exclusively being used. Initially, in the hypoxemic respiratory failure, if you use HFNC and if you realize that patient is getting tired, clinically looking at accessory muscles or perspiration or the CO2 is rising or the pH is going down, for a few hours you shift him to the NIV. And then, because NIV basically supports the muscles. It unloads the muscles. So we should utilize that for using as a complementary to the HFNC. And it should not be said that you can use one and you can't use the other one. That's my comment on that. Otherwise, I totally agree with you about. So, Dr. Mansi, when would you think of intubating the patient?
So, in a patient who is basically, showing sign, when you have used NIV as an alternative to intubation, again, your patient is likely to fail on intubation, NIV. So, a patient who is, too sick, he's in shock, he's requiring inotropes, you have to shift to invasive mechanical ventilation. Then, if your patient is in severe hypoxemic respiratory failure, as pointed out, PaO2, FiO2 for our department's protocol also less than 150, we are not pulling the patient on NIV at all because we are going to fail. If your patient of COPD is going more and more obtunded, there is no clinical improvement in terms of accessory muscle usage or work of breathing, and a patient has a lot of secretions, is unable to bring out. So there will be a time that you have to intubate. Any sign of metabolic acidosis setting in, so we should take it as an ominous sign. We should not continue in NIV for long.
In the interest of time. There
Yes,
are
sir.
no hard and fast criteria. No parameters can be given to intubate the patient. It is a clinical decision based on the arterial blood gases and other clinical parameters, which makes you decide. The important thing is that patient must not crash and have arrest. Preempt that and put and you nobody is loses life because you intubated, but patient may lose life if you don't intubate him in time. So there are various guidelines give various parameters. Like you say that PF ratio of less than 150 is an indication for intubation, but Gyanendra said in some patient you may be able to pull them out. So one reading should not lead you, but you have to give some parameters. So PF ratio of 150 is considered as indication for putting the patient on ventilator, and of course patient in shock and patient with not responding to NIV, not tolerating NIV. So many are there. So we have almost come to the end. So Dr. Hari, uh, what about weaning from NIV? When do you think that NIV can be discontinued?
So, we look at two, three parameters. One is the patient's respiratory effort. Has his work of breathing resolved? Has his gases stabilized? Or the primary condition, if it is an acute hypoxic respiratory failure, has the primary condition which led him over to the NIV has subsided or not? So probably I would think of weaning when the pH is above your 7.26 to 3.5 or compensated there with a good respiratory rate and not much of work of breathing. Now, how do I wean? That depends on two, three factors. Either it is a cold turkey way where you just stop the NIV, or we follow a slow, gradual weaning where I usually use a ratio. I put the patient on 1:3 or 1:4 ratios, and then slowly wean the patient off BiPAP.
So if I could add to that, because I haven't, so NIV can be used. What we have not discussed, NIV use of NIV for early extubation the patient. That's not we have discussed. That question was missing, and there is sufficient evidence that in patient with COPD, you can extubate early and put the patient on NIV, which may not be so true about uh, hypoxemic respiratory failure. But as far as the weaning from NIV is concerned, at the AIMS, we conducted a randomized trial, which is a published study in the, I think, Indian Journal of Critical Care Medicine. Uh, this study was conducted by Dr. Kavita. She was a DM student, now faculty at St. John's, Bangalore. I was her guide. So what we did was that we made three arms. In one, we reduced the pressure. In one, we reduced the duration. And in third arm, we abruptly stopped, as you said.
Yes.
The result was it was a randomized trial, not a observation trial. In this randomized trial, there was no difference in the outcome between the three. This is a published study. You can see it on the net. So the weaning from the NIV is either you reduce the duration or the pressure, or abruptly. It really doesn't matter. It is your judgment which is important depending upon the clinical. So Gyanendra, you were the first batsman and you are the last batsman also. The last question is, in which patients to give home NIV and what are the criteria?
Home NIV is usually given to patients with chronic respiratory failure, chronic respiratory acidosis, and mostly patients who have advanced COPD. That is the commonest indication for home NIV. Of course, other causes of chronic respiratory acidosis could be advanced stages of ILD, bronchiectasis, small airway diseases, neuromuscular respiratory failure, and so on and so forth. The important point is that once the patient recovers from acute exacerbation or acute on chronic respiratory acidosis, we need to check the ABG at the end of 1 month at the follow-up. And as per the hot HMV trial, the patients are candidates for home ventilation if the PaCO2 is persistently more than 53. That becomes the prime indication for long-term home NIV in these patients, and it has got good survival benefit also.
So I can't see the chat. And does anybody see the chats questions?
Sir, you
Yeah,
have to
it's
click on
there.
the chat box, sir. Yes, sir. Then
Let-
you will be able to see.
Most of the
So,
questions are already covered, sir.
but if you can see that it's not good to ignore them. I can't, on my PC I am unable to, because I'm
uh,
using.
sir, should I be speaking out the questions?
Yeah, please speak out the name. Some of the questions we'll take.
Sir, we have taken many other questions. Those which have not been covered, I'll take only those. Ankit from Uttarakhand asks, any role of NIV in pure metabolic acidosis?
So, Mansi, you answer since you are reading the.
So basically, we have to look at the cause of metabolic acidosis. So one of the commonest causes is sepsis. So in those patients, if your patient is going into shock and the shock is worsening, then NIV probably will not be the right choice. And of course, if you're asking other causes of metabolic acidosis, like a patient who has CKD or something, then if work of breathing is the only target in metabolic acidosis, then probably you can go for non-invasive ventilation in terms of having a control on work of breathing, but not as a modality in all types of metabolic acidosis.
So, if I could add to that, metabolic acidosis is not an indication for NIV. It is a concomitant respiratory failure, as discussed in detail, that would determine whether the NIV to be used or not.
So then we have, can we use NIV in cases of post-abdominal surgeries with respiratory failure?
So, surely, Gyanendra, you want to respond to that?
So NIV is not the contraindication for patients with abdominal surgery. In fact, most of the patients who undergo bariatric surgery, NIV can be given on the same day of the surgery when they come to the post-operative care unit. So, but then one must be really careful as far as the aerophagia is concerned and the abdominal distension. If you feel that, yes, again, a clinical decision. If the patient is not doing good and if there's a lot of aerophagia, then one must get away from the NIV. Otherwise, yes, post surgically, an IV can be given in these patients.
So one person, Rita from Maharashtra, Mumbai, says that can sedation be used in NIV?
So, Dr. Hari, you want to respond to that?
So ideally, sedation should not be used in a type 2 failure. The only exceptions I would probably think is a very agitated patient where, a little bit of sedation probably will help him calm down and make the institution of maintaining on NIV a little bit more comfortable. I have used Dexmed for these indication for the simple reason that it doesn't cause too much of a drowsiness there.
So there are studies. There are studies of using sedation in NIV. Several drugs have been used. It is not an absolute contraindication to use sedation. It depends upon the condition, number one. Number two, the extent of agitation the patient has. It has to be light sedation, and as Dr. Hari said, the short-acting sedative should be used, not the long-acting.
So can NIV be given when a patient is on vasopressor inotropic support?
No.
No, Gyanendra, she's already on. No, but
I think you will.
somebody is on low dose noradrenaline. Is it
Yeah, you can. Yes, sir.
is it an absolute contraindication?
No, sir.
Dr. Preeti, what do you say?
So Priti, madam has already left. She had to be there somewhere.
So it's not an requirement that the patient is in shock at the outset. That is rated as a contraindication to NIV. But a person who is on a very low dose of noradrenaline or whatever vasopressor, to my mind, and this is my personal opinion, that it's not an absolute contraindication to using NIV. Again, it's a clinical decision.
So rest of the questions have been covered. Just sir, I think too many people are writing about HFNC and NIV. Can you take up this question, HFNC versus NIV?
I've already said that, that HFNC both have a different mode of respiratory support. NIV basically gives the respiratory support and it unloads the respiratory muscles, whereas the HFNC is a mode of giving high concentration of oxygen, and it is believed that it can give up to 5 to 7 centimeter of positive and expiratory pressure PEEP. So therefore, to my side, it's a big no-no for HFNC for COPD type 2 respiratory failure. Although people use it, but I am quite against it because NIV works beautifully for that. As far as the acute hypoxemic respiratory failure is concerned, it's a topic for debate all the time. For several years you put two intensivists across each other, they will fight with swords. That HFNC better but there are several studies which have compared HFNC versus NIV. So you have to use the knowledge in a clinical context. And I've already said that in a hypoxemic respiratory failure where the CO2 is not high and the work of breathing is not too high, if the pH is not dropping, then I'll start with the HFNC. However, if the HFNC is being insufficient or the CO2 starts rising, may not be the above 45, even if it starts rising or the pH starts dropping, that will be the time to consider using NIV, and that we learned during COVID actually. And we actually used it. And sometime after using NIV for 6 to 8 hours, then you can switch back to, because NIV gives a lot of discomfort and claustrophobia, and the patients are more comfortable with HFNC, so you can use it alternately. So if I could summarize, if there's a type 2 respiratory failure, no HFNC, no NIV, only HFNC. In type 1 respiratory failure, that is hypoxemic respiratory failure, nothing to choose between the two. My choice is first HFNC, and then, but it's a matter of debate. And Mansi, you want to add something?
No, sir, absolutely the same views that as you.
So we have exceeded 16 minutes beyond 10 o'clock. Do you think rest of the questions are answered?
Yes, sir, mostly everything has been covered. I think no question has been left.
So, ladies and gentlemen, if I could summarize, we had an amazing talk on NIV and an amazing overview by Dr. Gyanendra, and I'm very fond of him. He really works hard to prepare this presentation with a clear understanding. We discussed every aspect of NIV, including indications, contraindication. There are a lot of contentious issues, but NIV has come a long way. And I think we all believe that all patients with respiratory failure, acute respiratory failure, unless contraindicated, should get a benefit of NIV to avoid intubation, and various modes can be used. So far as the modes are concerned, there is no much headway beyond pressure support ventilation. As Dr. Mansi said, that AVAPs and all, there are no randomized trial to show that they are better than the pressure support ventilation. This remains the main. It is also emphasized that in patients with cardiogenic pulmonary edema, which has become class 1 indication, the CPAP should be tried first. Only when there is hypercarbia or the CPAP fails, then NIV should be used. Same is true is obesity hypoventilation syndrome. And every expert agrees that one should not be overzealous with NIV, thinking that he is a big expert in NIV and he should continue to use it just because the SpO2 is 90% or 85%. You may see patient crashing and unrevivable if you become overzealous. So don't think you are the greatest expert in BiPAP, and use all the parameters and should have a legitimate and genuine, a good threshold for intubating, because you will be saving the patient by doing that. That's what we learned during COVID pandemic also. As far as the comparison between portable ventilator and critical care ventilator, I am giving my view here that for acute respiratory failure, in my experience, the critical ventilator works much better than the portable ventilator. The correction of the acute respiratory failure is much better. There is better control of oxygenation, there is better alarms and better parameters, except the leak. the leak compensation is better with the portable ventilators, and this should be understood. About the use of the mask, the for acute respiratory failure, oronasal mask is preferred, but for COPD patient, this is my personal opinion that the oronasal mask is not tolerated. Then you don't dump NIV, you can use nasal mask because 3 of the 7 studies, positive studies, actually used nasal mask. For chronic respiratory failure, the nasal mask is the preferred mode. About the weaning, there are no set methods of weaning. You can reduce the duration, you can reduce the pressure, and you can sometimes even withdraw suddenly, which we actually don't do. Usually, we reduce the pressure and the duration, and then find a comfort zone. And in COPD patient, you don't have to target at less than 45 CO2. That's what we have seen. Some patients keep walking at the PCO2 of 60. So that should be understood. So these were my comments and the summary of what we have discussed. I might have missed out because I have not written anything. I'm just using my fading memory to brief you what we discussed. And at the end, I have a pleasant duty of thanking all my panelists, starting from Dr. Parvaiz, Dr. Gyanendra, Dr. Mansi, and Dr. Priti, and Dr. Hari, who actually not only gave their astute knowledge and also their experience in the ICUs, because all of them are highly experienced. I also thank the audience, which are more than 1,000. It's heartening to see, when we are lecturing in a conference, if there are 100 people, we are very happy. But now we have 1,000 people listening to us. So it's really very heartening to know the interest of people. And I also thank Dr. Amita Nene and the Indian Chess Society for continuing this academic activity, and Mr. Sipla for supporting this activity and disseminating the information. With that, good night to all of you and thank you. And I hand it over to the organizers. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.